what this is, it's it's not that tough of an exam, but you do have to prepare for it. So, I mean, the first thing you have to understand is that you have to understand the structure of the exam, okay? So, they're basically two things. The first is OSCE and clinics. I mean, by now, all of you, whoever has gotten dates or whoever is going to give dates or something, will know that, this is how it is conducted. So basically, first everyone will have OSCE and then you will have clinics. So OSCE is conducted on 2 days, and then clinics will be conducted on 2 days. Okay, so what basically OSCE is that you will have no patients. So they will give you either a case scenario, they will have a laminated case scenario from, okay, and or they will give like, let's say in retina or anterior segment, they will give you a photo, and then there will be questions below the photo printed for some, or they can just ask you like randomly any question. In clinics there will be patient, and in clinics the most important thing they will need from you is the type of examination. Let's say you have a motility case. In that, they will ask you to do Hirschberg, or they will basically ask you they will tell you what you have to do. And if you just perform it, it should be fine. Okay, so I mean, if you can see my screen here, I've written that OSCE has 3 stations. Okay, so basically each one will have 20 minutes. So let's say the first station, this was my order, and every order will change for each individual. So I will tell you how it is also. Okay, it will basically be in a big room. At least this was how it was in Delhi. I don't know about other places. Let's say there are 3 stations, right? So they will have 6 tables and 2 examiners each. And you will be divided into morning half and afternoon half. In the afternoon half, 6 of you will go at a time, and then again you will come out after 20 minutes, and then your stations will change. Okay, so that's how it works. And let's say for general medicine, you will have 10 minutes. After that, there will be a bell. And then again, there'll be 10 minutes for motility and neurology. The same for anterior segment, and then 10 minutes, and then you will be asked on lid and oculoplasty. Again, same for posterior segment and glaucoma. Okay. And clinics also, there will be 4 stations, but this is 10 minutes each. So you have to be pretty quick here. And in each room, there will be 2 examiners. After 5 minutes, one examiner will stop asking questions, and the second one will ask you the other question. Okay, so now that you have the basic idea, and feel free to stop me anytime. You can always unmute yourself and ask me questions. Okay. So what I had first was general medicine, motility, and neurology. So in general medicine, I think I had a Brit examiner. Okay. So in that, he actually gave me a laminated case sheet which said there was a 75-year-old man with transient visual loss. That's all was there. Then he asked me what could the diagnosis be. So because it's a old man and transient visual loss, I said TIA, transient ischemic attack, and giant cell arteritis. And I also asked him, like, does she have do they have any other symptoms like jaw claudication or, pain while combing the hair? Then he said, no, whatever is written, that's all. You can elaborate on that. Then he asked me, what investigations will you do? So, like I've written here, I told him all the basic investigations. Basically, he wanted MRI brain, and for that is for TIA. Okay. And if it's giant cell arteritis, then he wanted temporal artery biopsy. Okay. And he asked me, how much will you take of the biopsy? And I told him it has to be a large biopsy because, there'll be skip lesions. And he also asked me the mechanism of the giant cell arteritis affecting the arteries. Like basically, he wanted to know which all layers will be affected. So I told him that. And then he asked me, how will you manage? So I told him if it's TIA, then you find out the cause, like look for embolus or thrombi. You basically find out why the patient has TIA. And then you refer to the neurosurgeon for further management. However, if the patient has giant cell arteritis, then you start with IVMP, and then after 3 days, you go on oral steroids, 1 mg per kg body weight, and then taper gradually over a prolonged 1 year. Okay, so yeah, this is the fourth question he asked. Like he asked me immediately after this. So he said, so this is an elderly man, right? So he asked me, if this is an elderly female on long-term steroids, what would you do? Then he asked me like, what are the complications? What do you have to do? So, like you basically have to tell the complications of steroids in individual. Like you basically start from the face, what will happen, like moon phases, and then there will be edema. And I started to list out everything. Then he was like, okay, there are multiple complications, but in this female, let's say she's had 2 or 3 children, what exactly would you tell her? So then I told him that maybe be careful when she has a fall to avoid falls because they will have calcium deficiency, like, on long-term steroids, that they would go into osteoporosis and all that. So he was like, okay, so then he seemed happy with that answer. Then he asked me, what precautions will you give? So then I told him, like, because she's on steroids, it's better to for that patient to not live alone and have like a support system so that if she falls or something, there will be someone to help her. So those were my two cases. Then again, this was the DKA. It was actually scenario. The diagnosis was what I told about DKA. What had okay, let me try and recollect. I think it was a 50-year-old man who had uh, like increased hyperglycemia, and then he fell down, and the patient had rapid breathing and sweating and all that. What is the diagnosis? Then I told that it was diabetic ketoacidosis, and he asked me what exactly is it. So basically, there are two types in diabetic ketoacidosis. Okay, if it's an elderly patient, it's different, and if it's young, it's different. So then I told him if it's a young patient, they will actually have hypoglycemic hyposmolar because they will have irregular. It is usually seen in type 1 diabetics who are irregular with their medication. However, in elderly patients, if it comes, then it can occur because of any intercurrent illness or sudden stress like surgery, hospitalization. Then he asked me, like, what are the clinical features? How did you come to this diagnosis? So then, because, from the history, you can find out if it's type 1 or type 2. And then there will be sweating, vomiting, Kussmaul breathing. In actually, what helped me come to this diagnosis was there was a fruity, it was written in the laminated sheet, they had written a fruity breath. So that was something which helped me. Fruity, rapid breathing. So that is Kussmaul breathing. And then, yeah, so then he asked me, how would you how would you manage? So basically, for diabetic ketoacidosis, you have to treat the dehydration first and then give insulin and then correct the potassium levels. This is the order you have to remember. Yeah, that's about it. And he asked me, how will you give insulin? So then I told him based on the capillary blood glucose, because in type 1, it is actually hypoglycemic. So you have to check that before giving insulin. And he also asked me, how would you correct the potassium levels? So you give potassium chloride. And I still had time. Usually they ask about 2 to 3 scenarios, okay? But I still had time, so he went on to the fourth one. So he asked me, okay, so now you've dealt with hyperglycemic. Let's say there's a hypoglycemia. What are the causes of hypoglycemia? Then there are multiple causes for hypoglycemia. You can just give 4 or 5 common ones. So I told him diabetics or irregular treatment like type 1 diabetics and alcohol, stress, delayed food intake. Then he asked me, okay, so what investigations will you do? Then like you have to tell all the investigations for these UK exams. You basically tell CBG, CBC, UNE, which is the urea and electrolytes, and he will interrupt you there. If not, then you can go SR, CRP, and chest X-ray to find out if there's anything else. Then he asked me, how would you manage? So I told him based on the blood glucose level, like capillary blood glucose. He was like, okay, this patient, let's say this patient was in the hospital and you have access to the lab, what would you do? Then because capillary is not that reliable, you actually take blood from the veins and then you can find out. And then you can give, based on the insulin levels and blood glucose levels, you can give uh, rapid acting glucose like sugar or chocolate or glucagon. So yeah, this was my 10 minutes. Then now I moved on to the neuron motility. So my first case was esotropia. I think they gave me pictures of a child with esotropic uh, gaze. So he told me this patient is 4 years old. And for 2 to 3 years, the patient had 30 prism diopters and it was variable. So the key here is the variable esotropia. That means this was a Duane's retraction. That was why he had esotropia. Then he asked me, how would you manage the medical and surgical treatment? Of again, Duane's, you tell the medical again, if it's just immediately you're starting out, you can just wait and give glasses or you can give Botox. And surgical, you can do transpositions. So coming to the second case, there was, I think this was just a case scenario. Uh, then he asked me, there was a 7-year-old boy with the lid swelling. What are the causes? So I told him that it could be most common is preseptal or orbital. Then there could be trauma. Then he was like, okay, so how would you differentiate between preseptal and orbital? So basically, in preseptal, the eye will be quiet, only the lid will be swollen, and there could be tender, and there will be increased temperature. Basically, all the signs of inflammation only in the lid, but the eye is white. But whereas in orbital cellulitis, the lids are normal. But the eye is very, you can start from the conjunctiva. You can say the conjunctiva is chemosed, congested, and there will be restriction in lid movements. Patient will have fall in vision. They will have ptosis. They will have discharge. Then there can be RAPD. They can have loss of vision. And he asked me the causes. So basically, for preseptal, it could be either an insect bite, or for orbital, it could be a tooth caries extraction. And orbital can also come from any other generalized septicemia. Then again, investigations, you again start with, for any investigations, you go with the CBC, CBG, UNE, chest X-ray, ECG, and all that. Okay, so we've gone over the differences. The management is again, you give antibiotics, oral or for preseptal you can give oral, but for orbital you have to give IV. Then you give anti-inflammatory. And once you find out the cause, you treat the cause. Complications of orbital cellulitis are basically loss of vision. If it's untreated, it can even spread to the intracranial, there can be intracranial extension. So, yeah. Then the third last one was abduction is restricted in a 60-year-old female. And the rest all were normal. Okay. So that's why I told him it's a sixth cranial nerve palsy. And since it's 60-year-old female, I told him it's sixth cranial nerve palsy. If it was again a young child, then maybe I would have thought about any restrictive pathologies. So sixth cranial nerve palsy. Then he asked me what are the diagnosis. Yeah, I told him the same thing what I said. Because of the age, it could be. Then I told him it could be either diabetes or hypertension or any intracranial tumors. So then he asked me, what is the mechanism of sixth nerve palsy, which is caused by diabetes? I told him it could be a microangiopathic cause, and yeah, that was my time. So then moving on to the anterior segment lid and oculoplasty section. Um, so yeah, this was again given as a laminated sheet. It was written a 45-year-old posted for cataract surgery with a refraction of +2 sphere with +3.5 SIL at 90 degrees in the right eye, and left eye +1 sphere and +2 SIL at 70. So he asked me what are the causes of astigmatism. I told him, see, basically this could be because of either pterygium or there could be any previous corneal scar or any other corneal surgery, or it could just be a lenticular astigmatism, or it. Then he was like, okay, so how would you treat astigmatism? If it is because of pterygium, then you remove the pterygium, wait for a month, and in most of the cases, it will reduce. If it is just because of a normal corneal astigmatism, then you can implant a toric IOL. So moving on to the second case, this he just asked me orally. He was like, okay, a young man comes to you. He had a fall of cement in his eye. What would you do? So the first thing you have to do is wash his eye, then check the pH after thorough wash. Then in slit lamp examination, you basically remove any debris which is present. Then he asked me on slit lamp, what would you find? So there can be conjunctival congestion, conjunctival ED, which is epithelial defect. There can be corneal ED, epithelial defect, and limbal ischemia. Then he asked me about the management. So basically, first you remove any debris, and based on the amount of ED and limbal ischemia, the entire treatment depends. So you give for any trauma, you give antibiotics, lubricants, steroids, NSAIDs and cycloplegics, and you give painkillers. So he asked me what are the complications, the early and late complications. If it is not, if steroids are not given and if the cement is not removed properly, it can keep releasing particles, and it can also cause dehydration. Cement has that property. So these are the early complications, and late ones, it can lead to limbal ischemia, corneal vascularization, scar. So he asked me, what would you treat if it's in late complication? You can do a slet for such cases. Then there was a clinical photo with ectropion. So he asked me, what are the causes of ectropion? Again, there are four causes of ectropion: senile ectropion, mechanical, neurological, and what was the other one? Mechanical. So then he asked me, based on each one and the management. So this was a pretty simple case. Remember that you will definitely get either an ectropion or an entropion, 100% in this. Okay. And entropion is very rare in India because of trachoma. We don't have trachoma cases. But however, if you're giving in Egypt or Jordan, then you might get a trachoma case. So then 1 month post cataract, vision was not improving. So what are the causes and management? Okay. So basically, You start from the anterior segment till the posterior. Anteriorly, what can happen? The lid can have, because of block, the lid can have ptosis. Then there in the cornea, there can be corneal edema, DM folds. Then in the AC, there could be uveitis. Or there could be traumatic zonulodialysis. Okay, iridodialysis. Then in the lens, it could be phakic or subluxated lens. Yeah, again in the vitreous, they can be, because if it's a nucleus drop, they can be vitritis, or in the retina, there can be CME or RD, and management of each one. Then he gave me a OCT picture of a cystoid macular edema and asked me the causes. It's pretty much a straightforward case, causes and management of cystoid macular edema. Then moving on to the clinical picture of a lower lid swelling. So basically, he asked me to describe the lesion. So this was actually a nodular lesion which was elevated, and there was a blood vessel present on it, like a telangiectatic vessel. And he asked me what are the diagnosis, differential diagnosis. I told him it could be chalazion or like a basal cell carcinoma. Then he asked me what diagnostic test would you do to prove that it is a basal cell carcinoma. Then I told him it could be a Mohs micrographic biopsy or frozen section. So you can do both. Yeah, and then he asked me how would you treat it. So based on the size of the lesion, again, it's different. If it's less than 1/3, you just remove it and suture the lids. But if it is a large region, then again you have to do reconstruction procedures. Okay, so coming to the posterior segment, this was actually quite easy for me at least. So this was posterior segment and glaucoma. Okay, so they asked me AT, that is applanation tonometry. How would you what are the causes of error? Again, you start from the machine. In the machine, there could be a calibration error. And in the patient, it could be when you're doing the technique, you could be applying pressure on the cornea, on the lid, which should be causing more pressure. Or it could be when you're overstaining or understaining. Then it could be any dry eye. In that cases, you won't get proper AT. Or there could be a corneal scar or a failed graft. It all depends on the ocular surface, basically. And it also depends on the corneal thickness. So then they asked me, like, how would a corneal thickness affect the AT? So basically, if it is thicker, you will get more reading, a higher value. So he asked me, how would you correct it? So for every 10 microns increase from the normal, you subtract 1 mm of Hg. Then they asked me, what is the normal corneal thickness? So I told them around 500 to 550. So if it is less than 500, you basically, for every 10 microns less, let's say if it's 490 and you get like 12 mm of Hg, then you basically add 1 mm to it. Then they asked me to describe the procedure of how to do an applanation tonometry. Then they asked me, let's say if the patient has astigmatism, how would you do AT? How would you deduce that in such cases? So what I told them was, there are basically, if you notice carefully, there is a red mark on the prisms. You can adjust it according to the refractive error. You keep it to the in the axis which has high astigmatism. You can, that is one method, or you can do 3 times and take a mean of that. That is the other one. So the next one was they asked me, a patient came, he's a young man with a hammer chisel injury. So what are the clinical features, investigation, and management? So again, for this, you go from anterior segment to posterior segment. It's always better to be systematic so that you don't forget anything. So starting from lid, there can be lid tear and conjunctiva. If it's conjunctiva, then there can be conjunctival tear, SCH, chemosis, or corneal tear. Then from the iris, there could be iridodialysis, or there can be iris prolapse into the cornea. If there is ALC rupture, there could be a traumatic cataract, or there could be a lens abscess. Or if the ion particle is in the vitreous, it could, if it is left alone like that, it could lead to siderosis bulbi, or it could cause RD. And management is investigations. You basically do again. You again start with CBC, UNE, X-ray, X-ray orbit, and CT orbit. You do for this. They asked me why not MRI, because it's a metal particle. You don't do MRI. Management is that you again give antibiotics, anti-inflammatory, and if there is a foreign body, it has to definitely come out. Okay, so moving on to SRF. He gave me an OCT picture in which there was a subretinal fluid. They asked me the causes of SRF. So it could be like a type 1 personality, or the patient has steroids. Then again, management is the same, like lifestyle management, and you can give here. They asked me, uh, I told them common things, and he asked me what spectrum of disease does SRF come under. Oh, I didn't know this, and this was my I didn't know this, but later I found out that it was a pachychoroid spectrum. Then he gave me a picture of Stargardts and asked me the basic things and management of Stargardts. He asked me if there's a management for Stargardts. I told him at present there is none. Then they also asked me what are the current medical management of glaucoma which is present. So I told all the 6 common ones like prostaglandins, beta blockers, alpha agonists, carbonic anhydrase inhibitors, and so they asked me the name of each ones, and beta blockers they asked me the mechanism of action, side effects, and contraindications. So in this, I actually had a little bit of time left. I thought they would ask me more questions, but they told me your exam is over. We asked 3 in each, so I just sat quietly till they rang the bell. So that is about my OSCE. If anyone has anything to ask, you can ask me. Okay.
Ma'am, I have
Yeah.
just one question.
Yeah.
You told about that 4-year-old girl with esotropia that is variable, no? So
Yeah.
that variability, is it because of the device or is it due to some accommodativity? Because usually variability, I'm not
I actually told him, okay, like refractive cause of like refractive and non-refractive. He was like, no, refraction is fine. And he kept insisting on variable, variable. So
What is the age?
4 years.
Four.
because in divans and all the esotropia whatever we measure will be almost same all the time, but means but will be different in different cases, but the variability usually happens in accommodativity. So I'm a bit confused, I don't know.
Maybe that's what he meant by variable, like because they're type 1, 2, and 3, right?
Yeah,
So,
maybe he meant the cases.
but he kept insisting on variable, variable. So I told all the cause of esotropia and he wasn't satisfied. And then the
Okay.
final thing I told was Duane's. Then he was like, oh, okay, yeah. Then he went on to the management of Duane's. So,
Okay.
Yeah. Okay, moving on to the clinics. So basically, what I would advise you is that you practice doing these tests multiple times because you will have not much time. 5 minutes for one patient is quite less if you've not prepared. However, if you prepare and you actually can actually time yourself when you're preparing, it is easy. You can do it because there are only few tests which you have to go over and over again. So my first one was sixth nerve palsy. They asked me, they just told me examine. So then for neuron motility, you have to do all these four tests, okay? Hirschberg, cover, uncover, and extraocular movements. That is the order you do it in. And after doing all these four, I told them the diagnosis. Then they asked me, what else will you do? I told them about diplopia charting. He asked me the causes of sixth nerve pulse. The most common ones are diabetes, hypertension. They asked me about the treatment, which is if it is, I told them if it's less than 6 months, then you can do temporary patching and give glasses with prisms. Or if it's more than a year, if it's less than a year, more than 6 months and less than a year, then you can give Botox. If it's not resolving after a year, then you can go for a surgical management. Then the second case I had was RAPD. So you basically have to ask them to dim the lights in this. They will tell you just examine the pupil. Again, for this, when they tell examine the pupil, for all pupil cases, asked to do it in dim light. Then again, you start with Hirschberg, direct, consensual, swinging flashlight test. And you also do convergence because in third nerve palsy, accommodation is lost. And then you also check for Argyll Robertson pupil, you check for accommodation. He asked me, why are you checking convergence? Then I told him, like, I'd like to see if there's meiosis during convergence. Then the third one, if there is still time. So basically, what they give you instructions also when you're about to go to the exam. You can basically do examine two patients. That is more than enough. Only if there is time, they will go on to the third one. So aim to do at least two patients quickly. Yeah. So third one, there was for me, there was an elderly man. They were like, this patient has visual field defect in one gaze. Which test would you like to do? Then I told them I'd like to do a confrontational field test. They asked me to perform it. So again, for all neuron motility, always start with Hirschberg. Then you do confrontation. For this patient, it is subjective, okay? The patients will sometimes give different answers to the examiners. It can vary slightly, but not a lot. So that's okay. They just want to know that you know how to examine the patient and they don't want you to actually treat the patient during your examination. So for me, the patient had supranasal, temporal, and infranasal vision loss. And in the left eye, he had only superior loss. This doesn't amount to any diagnosis. Then I told him, they asked me what are the causes. I told them it could be any intracranial cause, like tumors or trauma or anything. They were like, okay, what would you like to do? What tests? I told them I'd like to do visual field test and then MRI or CT. And they were like, what other ophthalmic examination would you like to do? I told them I want to do a fundus examination. And then he asked me if it's a glaucomatous or neurological field effect. Since it was very variable, I told him, like, it could be anything. Maybe most commonly, I told him it could be like a tumor because it wasn't respecting either horizontal or vertical midline. So, okay, moving on to lid and oculoplasty. My first case, there was a young man. he had a corneal, one eye was normal, and this patient in the other eye, he asked me, look, examine his, just check his left eye and tell me what is there. So this patient had corneal BSK with a pre-thusical contracted socket. So he asked me, why did the BSK happen? Why did this happen? Like, why did the phthisis in the contracted socket happen? And I told him BSK could have happened because it was a chronic non-seeing eye. I asked him what is the vision. Then he told me it's a non-PL. Then I told him that because of chronic non-seeing, BSK developed. Then he asked me, what would you do? Patient wants a cosmetic correction. I told him that you basically, for contracted socket, always start with glasses and then go on to evisceration prosthesis and everything. Okay, so I told him I'd give convex glasses, then give photochromatic glasses for cosmetic appearance. And you can do superficial keratectomy for BSK and corneal tattooing. And if patient is not happy with all this because it's a contracted socket, I told him I would do evisceration. I told him I would do a frill evisceration, leave a proper uh, leave what sclera so that they can implant prosthesis. And he asked me what kind of implants would you use. I told him I would use an integrated one because it's already contracted. Then no, I told him I will not use integrated. He asked me what are the types of integrated, what materials are there in integrated. Then I told him it was hydroxyapatite and quasi. So hydroxyapatite is basically, it will let the, fibrous proliferation happen inside it, and it will not let the implant basically sink inside the eye. But it has to be done initially. But for him, I think it wasn't done initially properly. That's why he developed a contracted socket. So then he asked me, can you do an integrated implant in this? And I told him, no, I will use a silicone implant based on the size of the socket. You can do size, you can do MRI and then measure the size. So the second one, actually, I had a small boy, around 6 years, I think. There was a ptosis, congenital ptosis in both the lids. So he asked me, okay, so look at his lids and describe. What do you see? Basically, his lid crease was absent in both the eyes. It was bilateral and there were lid lags. So he asked me, what are the features of congenital ptosis? Like apart from the three which are mentioned here, asymmetry is one of the most important things. And this boy also had asymmetrical ptosis. So he asked me, how would you manage this patient? I told him like I would like to do ptosis measurements. Again, you start with Hirschberg, MRD1 to levator function. And he asked me to perform levator function. The levator function for him was 4 in one eye. Then he asked me, what would you do? Since the LPS function is poor, I told him I would use frontalis sling. He asked me, what would you use as a sling? And I told him about facial latter and synthetic ones. So this was my 5 minutes. Then the next examiner came and asked me, what are the complications of frontalis sling? I told him there could be an extrusion, failure, and granuloma formation. So then there was moving on to the third case. There was a 40-year-old lady there. So he asked me examine her lid. Basically, I could see there was ptosis of the upper lid of the right eye. Then I asked to check pupils and extraocular movements and see if there's a third nerve involvement. However, when I examined both the eyes, when I checked the extraocular movement, it looked like there was proptosis. So he asked me, okay, examine the other eye. Then there was asymmetry of the proptosis. He asked me, okay, what are the causes? I told him, like, given the age, the most common cause of proptosis is thyroid. Then he asked me, how would you investigate? Again, you always start with thyroid profile, CBC, UNE, and all the common examination. And then he asked me, what other investigations would you do? I told him, like, I would like to do an MRI to see if there is any tendon sparing. and to see about optic nerve compression. He asked me, how would you check optic nerve compression? I told him that in her there was no RAPD, so it was normal. And then he asked me, what are the functions of optic nerve? So basically, the functions of optic nerve are vision, color vision, contrast sensitivity. I think there's one or two more. I I, I forgot to write it, but I think I mentioned it. Then he asked me like, what are the emergencies in thyroid eye disease? So there are two emergencies which have to be addressed immediately, which are optic nerve compression, corneal and corneal breakdown. He asked me, how will you manage each one? So if there is optic nerve compression, you do IVMP, and depending on how much proptosis is there, if it reduces, that's fine, or else you would have to do a debulking. Then if there is corneal breakdown, again, depending on how much of retraction is there, you first treat. If there is ED or exposure, then you treat that. You give lubricant, drops in ointment and everything. Then again, you can do debulking. You can remove the lateral wall and do tassorrhaphy for such cases. After 4 cases, there was still some time for me. So he asked me, okay, so examine this congenital ptosis boy. So when I was doing the MRD in one eye, the MRD was, it was like the lid was covering beyond the pupil. So he asked me about a negative MRD. Yeah. This was my second one. Yeah. Coming to the anterior segment. In anterior segment, see, neurology and motility, you will have no slit lamp, okay? Patient will just be sitting on a chair. Even for lid and oculoplasty, the patient will be sitting on a chair or a stool, whatever. For anterior segment, there will be a slit lamp. In this, there was one, I think, was it a young patient? Yeah, young patient with a corneal, they'll just ask you, just examine the patient. So then this patient actually had a corneal graft with aphakia. So they asked me, why did they do PKP for her? I told him it could be many things like trauma or ulcer, but most likely trauma because it's aphakic. Then they asked me difference between graft failure and rejection. So failure basically happens because of poor handling of surgical tissue or a poor endocell count, and it has nothing to do with the patient's immunity. But rejection can happen primary. There's again primary and secondary. So I told them about that. Primary can happen anytime between 4 days to 14 days. And then secondary can happen anytime till the patient dies. So they asked me what would you like to do for her? I told her that I would give place and secondary IOL after fundus evaluation. And moving on to the second case, they asked me to examine the anterior segment. This patient actually had like anterior uveitis with posterior synechiae and complicated cataracts in both the eyes. They asked me what are the causes. So, because it's bilateral, I told them it could be idiopathic spondyloarthropathy, inflammatory bowel disease, and Crohn's. They asked me the treatment. So basically, treatment, what I told them was I would like to find out the cause first and then proceed accordingly. But ophthalmic treatment was topical steroids, antibiotics, and cycloplegics. And based on the cause, you give oral steroids and whatever immunomodulatory treatment which is required for the cause. And they asked me, okay, since you said this patient has complicated cataract, what would you like to do before cataract? So I told him, based on the cause, I will do a full blood workup and do a cataract surgery under steroid cover. So they asked me, okay, since the patient you're giving steroids, what if there's a high IOP? I told them switch to a lower potency steroid, like switch from Predfor to Lotipred. They asked me, like, what would you do if IOP doesn't reduce with medical management? I told them you would have to do GDD because TRAB is likely to fail. So moving on to the third one. This girl again had a corneal scar from 3 to 6 clock hours with iris loss and pseudophakia. So they asked me what is the cause. It's very apparent that I told them it was a trauma. Then they asked me how would you manage this. So basically, in any trauma case, you do a primary repair. That is, whatever globe is open, you repair that. And then you think about vision, and then you think about cosmetic appearance. So the secondary repair was to do either for scar, you think about that. You can either do a talc, or then you think about IOL. If it initially it would have been a fake kick, secondary they would have placed a secondary implantation. I also told them because there was an iris loss, I would like to do a segmental iris implants. Then they asked me because okay, they didn't do DALK, so what would you do about astigmatism? I told them you can do toric, toric lenses. And I told them about multifocal and EDOFs, but I told them that I would actually do monofocals for this because, she can always use glasses for near vision. Yeah, so that is my anterior segment. In this also, I think I had like a couple of minutes left. So they're not going, some examiners do ask you questions even after, uh, you know, um, all the three patients are examined. But some examiners just ask you to sit quietly, so that's totally fine. And coming to the posterior segment, there was one patient sitting on the slit lamp, so they asked me to examine with 90D. I told them like I could see ERM. Then he gave me the OCT. In that, it was pretty evident. Then they asked me the treatment. They asked me about double staining, negative stain, and all that. And with the IDO, they asked me to actually see the pupil first and then examine the posterior segment. So in the pupil, I told them that there was a festoon pupil, probably, uveitic. Then in the fundus examination, there was a macular scar. And then they asked me what are the causes, what could have happened, and all that. So I told them and it was bilateral. So I told them it could be Behçet's, and if there is a lung involvement, then sarcoidosis, and since it's India, it could be tuberculosis as well. Then moving on to the third case, there was an optic atrophy. They asked me whether it was primary or secondary. So I told them it was a glaucomatous optic atrophy. So yeah, that's about it. If you have any questions at all at this point, you can ask. One thing which helped me was obviously now that you're in the group, these classes which Dr. Kaushik organized helped us a lot, whoever cleared it. So, thank you, Dr. Kaushik, for taking the time and organizing everything. Yeah. And Professor Muthuswamy group is amazing. So, I'm sure all of you who are in the group will clear it one way or the other. And do combined study if you get a study partner. That actually helped me as well.
Dr. Harika, thank you for your very valuable presentation. It is really informative. I have one question though.
Sure.
So, when we all discuss about pupil examination, it's always said that if the room is dim, you ask the examiners to, switch on the lights because you are supposed to examine the pupils first in the ambient light. but you said that you asked them to dim the light, so I'm a little confused here.
It will be it will be normal because my first exam wasn't the pupil case, no? So I examined it first and then you ask them to dim the light.
You examined first in the normal light and then you asked them to dim the light, right?
Yeah, that's right.
Okay, thank you.
Hi, ma'am. Thank you for this class. I have a doubt regarding the TRM photo. What is that double staining and negative staining?
Um, so the ERM, I think you can use trypan glue to stain. ERM will take up stain and the other one will not. I forgot.
Okay.
Okay, it's been a while. I'm a cornea
So
surgeon, so I would.
basically, this is double staining means you are staining ERM with something and you are staining ILM with something else. So you can stain ERM with triamcinolone or trypan blue, and the internal
Okay.
limiting membrane can be stained with brilliant blue green. So this is double staining. If you put two stains, then you will find the two structures differently. And negative staining is that when you are putting brilliant blue green, if there is a epiretinal membrane above internal limiting membrane, the area of epiretinal membrane will not stain. The other areas of internal limiting membrane will stain because the in the area of epiretinal membrane it is covering ILM. So ILM is actually not getting in touch with the dye. So that is called negative staining. So negative staining will reveal the ERM in a non-stained part, and the stained part will be internal membrane only. So these are two things, and these vital dyes are very important topics. You need to at least read, even though if you do not operate or you are not a retinal surgeon, you need to know the dyes, their percentages, and why they are used.
Okay. Thank you.
Yeah. I mean, I answered in the exam, but it's been a while, so yeah. That's the answer.
So any more questions? Candidates, please be more proactive and also examine the patients. That is very important. What I see from Dr. Harika is that she prepare very well and she definitely examined lots of patients outside her specialty. So that is very important. You examine all cases, including entropion, ectropion, ptosis, proptosis, corneal cases, retinal cases, anophthalmics, cocksocket, squint. So if you do not examine yourself, if you do not measure ptosis yourself, you will not be able to do it in the exam. So it is very necessary that you start examining your patients in this your setup only. So this is very important. At least 50 to 100 cases, you should be doing that, and it should come to your mind directly ki what next should be done. Also, pupillary examination. So this is very important.
Dr. Harika, in a congenital ptosis, if the pupil is covered by the lid, how will you measure this thing as minus? Means I don't know. That's why I'm asking. So how will you
Okay.
measure it as negative? How will you actually measure it? That's what.
Okay, so you basically do Hirschberg, okay?
Okay.
And you ask in the other eye, since congenital will always be asymmetric, in the other eye, the boy can actually focus on it. And
Okay.
you use a scale, or you can ask I actually asked the examiner to hold it, hold the torch, and you use a scale and actually lift the lid and see how much of lid excursion is there from the ptotic lid till the pupil.
Basically, how much you need to elevate the lid to see
See the
the
pupil. Oh, okay.
pupillary
So
Yeah.
the
reflex,
reflex.
corneal
Oh,
reflex. Yes.
Yeah.
okay. Okay. I understood.
For me,
Understood.
I think it was -2 or something like that. Yeah, of
Okay. Okay. Now I understood. Yeah. Thank you.
course.
So please do these examinations yourself. And if you have any doubt, you can ask in the group. If you are not doing examinations in your area and you think that you will do it in exam and you will definitely fail. That is for sure. So
Yeah.
and this entropion, ectropion, ptosis, proptosis, these are very common cases and most likely they'll be given, including like this exophthalmometer hurdles or lutes. So they will most likely be there, and you need to know how to use those things.
Yeah, Dr. Kaushik's right. I didn't know IDO. I don't do IDO at all. I only use 90D, but for the exam, I actually saw like 50 to 100 patients before going. So, yeah.
So thank you, Dr. Harika. It was an excellent class, and you actually, it shows that you had prepared very nicely. That is what the candidate should take from here, and they should examine also. Patients personally practice. If you do not practice, then it is most likely a plan to fail only. And obviously, we are trying to help, but it is candidates' own effort and their persistence and their dedication that makes them pass. And I thank Dr. Harika for giving her valuable time for the help of like other candidates. So thank you. Are there any other comments?
Thank you very much, Dr. Harika and Dr.
Thanks.
Kaushik. It was
Thanks.
very
Thanks.
Dr.
useful.
Kaushik. I mean, I gained a lot by joining and from your classes, so I'm happy to help. Uh, You can always, anyone wants any help. And I'm a cornea surgeon, so if you have any doubts at all, you can feel free to text me, and my email is here. So on Telegram also, you can text me anytime.
Okay, thank you.
Thank you.
Thank you, Dr. Harika. Good day.
Thank you.
Good day.